for joining me on Saturday morning. I will just share my screen. Yeah. Hi, I am Dr. Parin Patel. Shall we start? Hello.
Yes, sir, please.
Yeah, please start.
Yeah, I am Dr. Parin Patel. I am as Dr. Kaustubh has already introduced me. I don't want to go into detail of that. I'm basically practicing at present at SCG Asta Cancer Center, Ahmedabad. And today we will be discussing regarding the skull-based malignancy, especially on the anterior skull-based malignancy. It is a huge and wide topic. So I would like to concentrate on the anterior skull-based malignancy. We will be discussing on the various parameters that have been mentioned, starting from the histology to the survival. So let us start that from the beginning. The skull-based tumor, as you all know, it includes a variety of the neoplasm, benign as well as malignant. But here we'll be discussing only regarding the malignant tumors. It can originate from the paranasal sinus tumor, or it can originate from the skull-based bone of a meninges or the brain. So tumor can be a bony origin, or it could be a soft tissue in origin. Tumors originating at the different sites have the different histologies and differ in the pathophysiology. So biological behavior are also different, and their sensitivity to the chemo as well as the radiotherapy is also different. So this everything has to be taken into consideration before planning or before treating any case of the skull-based malignancy. As you go through the anatomy of that anterior skull base, which may basically more comprise of the paranasal sinus tumors and the surrounding orbit, the most of the tumors are arising from the nasal cavities or paranasal sinus tumor and extending intracranially, or it can extend laterally into the orbit. So if you see from above, this is foramen cecum, that is just posterior to the posterior table of frontal bone. So the anterior skull base, there is no watershed line for the demarcation of the anterior skull base, but we have taken from the anterior table of the frontal sinus up to the planum sphenoidale. It comprises of the anterior skull base, which includes this foramen cecum, crista galli, roof of ethmoids, cribriform plates up to the planum sphenoidale. The laterally, the roof of the frontal sinus, the roof of the orbit that is formed by the frontal sinus, it forms the lateral wall of the anterior skull base. If you go through the incidence of that malignant paranasal sinus tumor, it comprises of only 3% of total head and neck tumor. And it's more common in the Caucasian, that is white people, but nowadays it has become more also increasing in the incidence in the Indian population also. Also, the normal age group that we saw this malignancy is around 50 or more than 50. Most of them tumors are derived from the epithelial lineage. That is 55% of the tumors. 30% derived from the mesenchymal, that is the bone or the skeleton muscles that is present there. 15% of the neuronal origin, that is neuroendocrine or the malignant peripheral Naushit tumors. Then the lymphoma, plasmacytoma, and the metastasis to PNS comprises very short, very small percentage, that is less than 1% of the tumor. If you go through the etiology, what causes this malignant tumor, most of the cases are we don't know the exact etiology, what causes this malignant tumor or what was the exact reason for that, but various environmental as well as occupational pollutants are responsible for that and have been attributed, like aflatoxins, formaldehyde, chromium, nickel, mustard gas, polycyclic aromatic hydrocarbons. This wood dust is common in the woodworkers in the European region. It mostly causes the adenocarcinoma. This is also increasing in Indian scenario, where they are not using the safety precautions like mask or N95 mask or adequate safety precautions. And smoking is also one of the important causative factor for this malignant tumor of PNS. If you go through the WHO histological classification, WHO histological classification, there are the various n number of the tumor mentioned in that. You don't have to remember everything. There are the few common histologies that we encounter in our day-to-day practice that I will enumerate. So these are all in the descending order that we see in the Indian populations. The squamous cell carcinoma is the most common leading one in the paranasal sinus tumor, then followed by the adenocarcinoma, which may be a I-type type or the non-I-type type. That is the intestinal type or non-intestinal type. So followed by a sarcoma, that could be a bony sarcoma like the osteosarcoma, or it could be a rhabdomyosarcoma or alveolar rhabdomyosarcoma. Then followed by this esthesioneuroblastoma. This is increasing. The ENB trend is increasing in Indian population. Then the adenocystic carcinoma, followed by melanoma. Then the sinonasal undifferentiated carcinoma, which is known as the SNUC. Mucoepidermal carcinoma as well as the lymphoma. So these are the all decreasing. This is all in decreasing order, which we see commonly in our routine day-to-day practices in Indian scenario. Which are the most common site of this malignant tumor origin? So if you see, the 60% originate in the maxillary sinus, 22% in the nasal cavity, and the very few, that is 3% or less than 3% in frontal and the sphenoid sinus. This has been taken from the E.R. Banna from M.D. Anderson book, Comprehensive Management of the Skull-Based Pathologies. But it is almost similar to all the findings, all the literatures in the world. Now, how we stage this tumor? There are the two methods of staging this tumor, TNM classification and the modified Kadis classification. Generally, what we followed is a TNM classification. It is separate for the maxillary sinus as well as for the nasal cavity. So, if you go through this TNM classification, so we will simplify it by putting some pictures of the TNM classification. So if you see here on the left side, T1 of the maxillary sinus, it is located only into the maxillary sinus without any bony erosion. This is very rare tumor to find. T2 on the right side, if you see, so there is an erosion of the medial wall of the maxillary sinus, as well as there could be erosion of the palate or alveolar process of the maxillary sinus in T2. In T3, the tumor extends anteriorly, superiorly, and posteriorly. So there is erosion of anterior wall or posterior wall or the floor of the maxillary roof of the maxillary sinus. Then it comprises of the T3. In T4A, it is a advanced tumor where it enter into the skin of the cheek or into the anterior orbital contents, or it may enter into the pterygoid plates or the frontal sinus or the sphenoid sinus, or in the infratemporal fossa, all constitute the T4A. In T4B is a common for both the nasal cavity as well as this. So whenever this T4B cavities, T4B tumors are there, it could be because of the massive dural involvement or the brain involvement. Then it could be because of encasement of the internal carotid artery or orbital apex involvement. This all comprises of the T4B. So whenever you are seeing this patient of the nasal cavity or the sinus tumor, you should have this charting readily available at your center, so that you can easily, after doing the scans, you can easily make it out which stage of tumor is there. This is for the nasal cavity tumor. In the T2, it is located to the one subside as well as extending to the other subside, that is the nasal cavity as well as ethmoids. In T3 tumor, it is almost similar to the previous one, but the cribriform plate erosion or minimal lamina papyracea erosion or the extent to the maxillary sinus of nasal cavity tumor comprises the T3. And T4A and T4B is almost similar to the maxillary sinus tumor. So to simplify this, this modified Kadis staging comes into picture. It is commonly used for the esthesioneuroblastoma, but nowadays people have started using for the sinonasal undifferentiated carcinoma, and I see in near future it might replace this other TNM classification. So in stage A, the tumor is confined to the nasal cavity. In stage B, tumor involves nasal cavity as well as surrounding paranasal sinuses. In stage C, the tumor extend beyond the nasal cavity and paranasal sinus, that is extending laterally to the orbit, superior to the intracranial extension, or the laterally to the infratemporal fossa, or it enter into the this lamina that is discussed. And the stage D, it is a extension to the distant metastasis or cervical lymph nodes that comprise of stage D. So this make our classification very simple and help in planning us better. So what is the pathophysiology of spread of tumor? How this tumor spreads? So suppose if it is a maxillary sinus tumor, it can extend superiorly. Into the cribriform plate or roof of ethmoids, and then from there it enter into the intracranial extension. It can extend medially, it can go posteriorly, and it can also enter into the inferiorly into the alveolar process as well as into the palate. So these ethmoid tumors on the second one can extend laterally and extend into the orbit, involving the anterior orbital contents as well as the posterior orbital content, orbital apex, and from there enter into the medial cranial fossa. This is a classical presentation of extension anteriorly into the cheek tissues, that is the skin, subcutaneous tissue, and involving the infraorbital nerve, and from there it enter into the V2, and from foramen rotundum it enter into the Meckel's cave. So this is there also the perineural spread, and this perineural spread is common in the adenocystic carcinoma, squamous cell carcinoma, and also in the mucoepidermal carcinoma. They have the high affinity for the perineural spread. So what are the symptoms or signs, means how the patient will present to you? Most of time the nasal blockage is the most common complaint, unilateral or the bilateral. Whenever there is a unilateral nasal obstruction and the patient present to you, that is long-standing unilateral nasal obstruction, you should evaluate it properly rather than give some medications and go. It will be clear up with the medication, because most of time unilateral nasal obstruction in the age around 50 or 54 more suggestive of some sinister pathology. Then the nasal discharge is common. It may be associated with the blood tinge, or there may be a frank epistaxis. If the tumor is extending to the orbit, then it may lead to the orbital swelling, proptosis, lateral displacement of orbit. There could be a diplopia because of involvement of these extraocular muscles, or because of involvement of the abducens nerve. Ophthalmoplegia is there when there is a cavernous sinus involvement is there. So the eyeball become fixed, the extraocular muscles are involved, as there is a no movement of the eyeball. The headache is common when the tumor extend intracranially, or there is a involvement of the dura. So it is associated with the severe headache. Facial swelling, as we already seen, when there is an anterior extension or the compression of this subcutaneous tissue involvement, it definitely produces the facial swelling. Neurological symptoms are there, which may comprise of the headache, but seizure, sometimes we see with the seizure in the case of the massive brain involvement. Some patient may present with a seizure, involuntary loss of the bladder and the bowel control, but it is very in advanced stage. Cervical nodal mets presentation is very rare. Two tumors, that is a squamous cell carcinoma and essential neuroblastoma, are associated with more than 20% of lymph node mets. So these tumors may present along with cervical lymph node mets, but other tumors are very rarely present with cervical lymph node mets. Once the patient is present to you, how will you diagnose this tumor? So in OPD procedure, we normally do the 0-degree rigid endoscopy, nasal endoscopy. This will help in the comparison between the previous pre-treatment and post-treatment. Also, suppose if the patient we send for the neoadjuvant chemotherapy, this will also help in comparison between the pre-anesthetic or the post-anesthetic comparison. So this video that I am playing is of the pre-anesthetic squamous cell carcinoma of the right nasal cavity. And the next video is after the first cycle of the anesthetic. So this will help in our subjective assessment whether the tumor has responded or not responded. This is not an objective assessment, but it provides us a good subjective assessment whether there is any clinical response or there or not. So this is a post-NSCT video. You'll find at least 15 to 20% regression of the tumor. So this will help in our planning whether to continue the same neoadjuvant chemotherapy or we want to change some other molecules. So imaging is the most important thing. Before taking any biopsy, imaging is a must. Where CT and the MRI both are complementary to each other, and at our institute as well as the major institute in the world, both investigation are carried out, and both are complementary to each other. CT will provide bony information, detailed bony information like erosion, lysis, thinning, expansion, calcification within the tumor, while MR will provide a better soft tissue assessment, like differentiating it from a sinus secretions, or there is a dural involvement, or there is intracranial extension is there, or the orbital involvement is there, that is intraconal extension is there, or whether there is extraconal extension. These are the information that will be provided by the MRI. MRI also provide the perfect information regarding the perineal spread of the tumor through the V2 up to the foramen rotundum or Meckel's cave or any other nerve involvement. So this is a small video where we did an MRI. On CT scan there was no dural involvement or means we are not able to identify the dural involvement or minimal brain involvement. But when we did MRI, we found that there is a right side, there is a small amount of dural involvement as well as a minimal brain extension was there. So this MRI definitely plays an important role, and it is must for any cases of the paranasal sinus tumor. This will help in changing our treatment plan. Another comparison between the CT and the MRI. On the left side, if you see the CT scan, there is a huge tumor in the midline along with a lateral extension to the orbit and compressing the orbit. So if you go on this, there is a high grade tumor. If you go on this CT scan only, you will be definitely give some anesthetic, or you can resect this orbit because of the close approximation of tumor. But when we did MRI, we find that it is just a cystic swelling close to the orbit and nothing, and the tumor is away from the orbit. So this will help in changing our treatment plan, surgical plan, and the preserving the orbit. So MRI is a must along with the CT for any paranasal sinus tumor before taking any biopsy. So there is always a doubt whether there is orbital involvement or not, because orbital exenteration is associated with the social stigma. So whether to preserve the orbit in this paranasal sinus tumor, it is one of the headache for us as well as for the patient. So we generally use this modified INAT classification given by the Mario Turi Zanoni paper from 2019 from Italy. They have divided the grading of that orbital involvement. In grade 1, there is erosion or destruction of the medial orbital wall, that is lamina papyracea. So if you see this picture A, there is erosion or destruction of the medial wall of the lamina papyracea in the grade 1. In the grade 2, there is an invasion of the periorbital layer or the focal invasion of the extraconal periorbital fat. So if you see this B, there is an invasion of the periorbital layer and the focal involvement of this orbital fat. So this grade 1 and grade 2, we still can preserve the orbit. But in grade 3, there is invasion of the orbital contents, that is anterior 2/3 of the orbit, including the extrinsic, that is ocular muscle, optic nerve, ocular bulb, or skin overlying the eyelids. So in this grade 3, we can't preserve the orbit. We have to resect the orbit either upfront or after the anesthetic, but we have to resect the orbit for the safety margins, provided the tumor is a high grade tumor. And in the grade 4, there is involvement of the orbital apex. So in the D picture, you can see there is a involvement of the orbital apex close to the IC, and this make it the tumor unresectable. because we can't get a proper adequate margin at orbital apex. And the PET CT scan, obviously the PET CT scan we always recommend in the advanced stage T4A, T4B, and whenever there is a patient present to us or with the nodal mets, we always ask them for the PET CT scan. A few of the histologies that are high grade like squamous cell carcinoma, adenocystic carcinoma, melanoma, SNUC, nut carcinoma, and the sinonasal teratocarcinoma, and the ENBs are the histologies. Whenever the patient present to us, we always recommend the PET CT scan, because most of the patient of the PET when we recommend, this is a case of the sinonasal carcinoma, squamous cell carcinoma of the nasal cavity T4A. The T4A is because of the involvement of the skin of the nose, and when we did a PET in this case, we found there is a multiple pleural nodules in this case. So obviously, all the entire planning or the plan of management will change from the curative to the palliative purpose. And the biopsy. So after all the imaging, we'll go for histopathological examination and the IHC. Immunohistochemistry is a must, because we all know for the diagnosis of this tumor, we require a good pathologist, as well as because histology is a king. Histology will determine the management of the tumor, the prognosis of tumor, survival of tumor, everything will be determined by the histology. So most of the time when we took a biopsy, generally the biopsy says that it's undifferentiated sinonasal tumor. So which needs to be differentiated into whether it is an epithelial tumor, like whether it is a SNUC or NUT or SCC or other epithelial variants, or it is a non-epithelial tumor. So like it could be a neuroectodermal tumor like ENB, that is SH neuroblastoma, primitive neuroectodermal tumor like having sarcoma, melanomas, or it could be a hematolymphoid tumors, or it could be a mesenchymal tumors, rhabdomyosarcoma, synovial sarcoma. But everything has to be differentiated properly for the proper planning of the management, because each and every one has a different planning protocols. So histology is a must to define properly before starting any treatment. So various common immunohistochemical markers that were used routinely in our practice day to day. For adenocarcinoma is CK7 and CK20 positive. For melanoma, it is around HMB45 or S100 positive. For squamous cell carcinoma is a pan-cytokeratin positive. Sinonasal undifferentiated carcinoma, pan-cytokeratin positive. Neuroendocrine carcinoma is a chromoganin and synaptophysin, both are positive. For the rhabdomyosarcoma, desmin and the vimentin, which are for the smooth muscles, they are positive. For the non-Hodgkin's lymphoma, the CD45, CD20, and for that having sarcoma, CD99 positive. So these are the common markers that we use. There are the other multiple markers that are available, but these are the commonly that we use initially for differentiating the tumors. Once you have got the diagnosis, this is this particular histology of the tumor, then there comes the management of the tumor. So how will you manage this sinonasal malignancy? If you go through the NCCN guidelines to 2024, it is a little bit confusing, and it has given a blanket treatment for everyone. If you see the pathology, means it is a little confusing. If you go for T1, T4 stages, then the treatment modality is divided into T1, T2 will go for either resection, or you can go for either definitive RT. If it is a T3, T4, you can go for resection, or you can go for induction chemotherapy, or you can go for concurrent CTRT. So it is given a means broad spectrum. Okay, either you can do this or you can do this. Definitely this will confuse the clinician. So rather than to go for this blanket therapy, we should plan our treatment of the sinonasal malignancy according to the histology. So it should be histological driven. There is a beautiful paper by Paolo Castelnova as well as Mario in 2016 from Italy, who has given how to manage different histologies accordingly on the basis of the different protocols. So, for example, if you are managing the squamous cell carcinoma, which is the most common pathology if you see worldwide, and for T1, T2 tumors, surgery is recommended, followed by adjuvant RT if it is in case of T2 or more. For T3, T4 tumor in all the squamous cell carcinoma, induction chemotherapy is preferred, followed by a reassessment, surgery, and then adjuvant treatment. So when we saw this paper of Iya Vanna from MD Anderson, they found that 70% of the patient will show the more than partial response of squamous cell carcinoma after the induction chemotherapy. And this will help us in better resection of the tumor. It is more like a debulking. It is a chemo debulking. This will help in the better resection of the tumor, well, to take the better margins, and the survival of the patient definitely increases. So, in case of squamous cell carcinoma, we always give the adjuvant RT if it is a T2 or more, and adjuvant RT should cover both the neck, as the probability of the neck node metastasis is more than 20%. When we go for other pathologies like adenocarcinoma, which is more common in the European setup, it is mostly an occupational hazard. If it is a T1, T2, definitely it's similar to the SCC surgery followed by an adjuvant RT. But if it is a T3, T4, then what we do is we see for a P53 mutation. That is a intestinal type and the non-intestinal type. In intestinal type adenocarcinoma, we look for a P53 mutation, whether it is a functional or not. If it is a mutant that is a functional type, we always prefer to give a neoadjuvant chemotherapy on the basis of cisplatin as well as etoposide, followed by a surgery and then adjuvant RT. So there's a beautiful paper by Lisa Licitra and the Paolo Bossi, and they found that the survival increases in the patient who are given the cisplatin as well as etoposide in the ITEC type, that is the intestinal type adenocarcinoma with P53 mutation. Another histology is esthesioneuroblastoma. So surgical resection is a must for the esthesioneuroblastoma, followed by adjuvant RT in all the cases. But with the Himes grading 3 and 4, that is a very high grade tumor. Normally all the institutions in the world prefer to give some form of the neoadjuvant chemotherapy like cisplatin, etoposide, and followed by a definitive surgery and followed by adjuvant RT. So most of the grade that we encounter in our day-to-day practice is Himes grade 3 and 4. So most of our cases of esthesioneuroblastoma will go for a neoadjuvant chemotherapy followed by a definitive surgery and adjuvant treatment. Adenoid cystic carcinoma, always surgery is the first line of treatment, as there is no definitive chemotherapy or the target chemotherapy available for this adenoid cystic carcinoma, which can be used for a neoadjuvant setup. All the adenoid cystic carcinomas should be considered high grade. They have the high propensity for the perineural spread, so surgery should be followed by adjuvant RT in all the cases for the better locorenal control. The adenocystic carcinoma is the one tumor where we have the solitary mats in the lung or 1 or 2 mats in the lung, but small mats without any symptoms, even though we can do a primary surgery followed by this adjuvant RT. In adenocarcinoma, GTR, that is a gross total resection followed by RT, also give us the good survival and the good locorenal control. SNUC, that is a sinonasal undifferentiated carcinoma, is a very aggressive tumor that has a high propensity for distant mets. So in each and every case of the SNUC, most of the time the SNUC present with the grade 4A, stage 4A as well as the stage 4B. So it is a highly chemosensitive tumor. So in all the cases of SNUC, we give NSCT followed by assessment. Whether it is operable, then we'll go for surgery and followed by adjuvant RT. Mucosal melanoma, highly aggressive, as we know, always most of time 50% of time associated with the distant mets. So surgery is the first line of treatment with the free margins. And there is also one of the good articles by this European, one from the UK and one from the Italy. They say that minimal invasive endoscopic approaches are generally associated with the better survival rates than obtained with the external surgeries. Followed by all the cases of mucosal melanoma should be followed by adjuvant RT. This adjuvant RT will improve the local control or regional control, but it can't control a distant this distant mats or the survival. At our institution as well as in the TMH and other world institution, all the cases of melanoma will go for after the completion of adjuvant treatment. All the cases will go to the med-onco for tumor board decision and for whether they should be given maintenance chemo or immuno trial. Most of all the cases of the melanoma at our institution will go to the med-onco for the chemo or immuno trial, and they will be given this immuno for therapy for at least 1 year or 2 years, depend on the how they tolerate it and what are the side effects. And few of the papers it has been found that this immuno trial will improve the survival in the patient of the melanoma. So what are the common chemo agents that are used for NSCT for the TPF, that is the taxane, platinum, and the 5-fluorouracil? We commonly use for epithelial tumors. The cisplatin and etoposide commonly used for this neuroendocrine and the estrogen neuroblastoma. Then this VAC, that is the vincristine, actinomycin, cyclophosphamide, or vincristine ifosfamide is used for the tryptomyosarcoma. So for the metastatic disease, we always send our patient for that MDT discussion, and after MDT discussion, they are going for systemic therapies. And for the unresectable tumor, we also send it for the systemic therapy. For the unresectable tumor, after systemic therapy, we reassess the patient or reassess with the PET and MR, and we see that whether there is a good response or not. And after that, we also do again MDT, that is a tumor board discussion, whether this patient is feasible for the definitive CTRT or not. So for unresectable tumor, there is a hope that after a systemic therapy, if there is a downgrade of the tumor, we can again send it for a CTRT. So what approaches should we use for the surgical resection? There are the two approaches, open as well as endoscopy. So first I will go for it open. These are the lateral rhinotomy, Weber-Ferguson, modified Weber-Ferguson. This all known as a transfacial incision. The other second one is a combined facial as well as the bifrontal craniotomy, which is known as a classical CFR. Then other is a subfrontal craniotomy, which is known as Raves approach. The fourth one is a mid-facial degluing or the cranio-orbital approach, and the unilateral maxillotomy approach for the infratemporal fossa. But nowadays we are using very less open approach. Most of the time we are using endoscopic exclusive or endoscopic combined with the open bifrontal craniotomy. So if you see for endoscopic, endonasal endoscopic approaches, there are the different approaches like transcribiform approaches, transcellular, transplanar, transpterygoid, as well as a transclival. So this is the exclusive endonasal approach. Sometimes we combined with the endonasal, we combine with the bifrontal craniotomy, which is known as a cranioendoscopic resection. These are the transfacial incision from the starting from the first in the nasal subunits, that is on the lateral rhinotomy. If this lateral rhinotomy extend over the upper lip, it is known as the modified Weber-Ferguson. Sorry, I forgot to mention that. And when this modified Weber-Ferguson incision extends superiorly over the eyebrow, it is known as a Lynch extension. And this is a lateral extension into the this is a lateral extension of the modified Weber-Ferguson, and this one, the last one, is a subciliary extension of the modified Weber-Ferguson. So these are the all approaches, depend on the location and the site of the tumor we have to select. I will show this bifrontal approach, which we use commonly for the CFR or for the combined cranioendoscopic approach. Here we are given a incision from one preauricular region to other preauricular region, and we have raised this flap up to the anterior-orbital rim. And in this second right picture, we can see that there is a pericranial flap that we are using has been raised. So this pericranial flap can be raised independently or after raising the entire this subcranial flap. This temporalis fascia we can use later on if the pericranial flap we are not able to harvest properly. This temporalis fascia is also used for the reconstruction of the skull base. In this case, we have done a bifrontal craniotomy. This approach is always done along with the help of the neurosurgeon. So never do it alone. It should be done with the help of the neurosurgeon. Now we want to discuss regarding the principles of endonasal resection, whether the sinonasal tumor can be resected endoscopically, endonasally, and whether they provide a good margins or not. That is a debatable topic, but there are the various literatures which say that definitely they can be resected. So this endonasal technique starts in early 2000, that is around 98, 99, and the oncological principle remains the same for the endonasal and open, that is to achieve the good adequate margins all around the tumor. In endonasal technique, sometimes end block resection may not be possible, but the final margins in all dimensions should be free of the tumor. Basically, what is the principle that we do a centripetal dissection, that is from periphery to the center, that is in a sequential manner and keeping the tumor attached to its origin, which is resected with a good margin, that is soft tissue as well as the bony. So this is the main principle of endonasal resection. I will just show you the small video of that endonasal resection. Here we are dissecting we have already done the centripetal dissection, that is from periphery to center, and the tumor is seen attached to its origin. And now we will achieve the good margins all around soft tissue as well as the bony surrounding the tumor. This is a cranioendoscopic approach, that is a combined approach, endoscopic plus open approach. So we have delineated our tumor superiorly. We have taken a good dural as well as a bony margin superiorly, and now we are dissecting from the below, taking all the margins from the all around the tumor, that is the bony margin. Now we'll remove the tumor origin with the good margins. Later on, we will drain out that sharp bony edges surrounding that tumor removal with the help of the drill. So these are the various evidence where it shows that the endonasal endoscopic resection are able to achieve good margins. I don't want to go into detail, but for that endonasal endoscopic resection, you require to be trained properly. There is no shortcut for them, and it is a time-consuming procedure, but definitely it has a various advantages. I will show you that. So it has a comparable survival compared to open approach. It has a better cosmetic result because there is no visible scar, and that bifrontal craniotomy or bifrontal approach that we do is the scar is in the just behind the hairline, so it is also not visible, and it provides a better visualization of the neural as well as the vascular structure that can prevent the damage of that neurovascular structure. Even the fewer complications are there of endonasal and the shorter hospital stay. Definitely it improves the quality of life. We'll see in the last. There is one topic on the quality of life. It is a much better in the endonasal endoscopic resection compared to the open approaches. So now we move on to the contraindications. So when we won't do the endoscopic or endonasal approaches, so whenever there is an infiltration of the nasal bones are there, palate, skin or subcutaneous tissue, there is endonasal is contraindicated. Whenever there is a massive involvement of frontal sinus or erosion of the lateral or anterior or inferior bony walls of the maxillary sinus, or the massive involvement of this lacrimal pathway, Then the involvement of the infratemporal fossa, orbital content involvement or the floor of the orbit involvement where we need to resect it, which is not possible endonasally, and the massive involvement of the dura or the that is dura over the orbital roof crossing the mid-pupillary line or the brain parenchyma infiltration, which is not possible to resect endoscopic exclusively. It may require the combined approach. So these are the few contraindications where in the left one it is extending intraconally, extraconally, as well as the orbital floor is damaged. So we won't be able to resect this endonasally. And the lower one, there is a dural involvement, that is a extensive dural involvement for taking the margins. We might have to do a bifrontal approach. And in the upper one there is a skin of the nose involvement T4A. So in this case we also able to not able to do an endonasal approach. And the last one, that is a skin close to that right orbit involvement is there. So in this case this is a high grade tumor, so we need to resect the this orbital exentration along with the skin of the external skin, along with that suprastructure maxillectomy in this case. So it is also not possible endonasally. So what are the conditions where the patient of sinonasal malignancy are considered to be inoperable? So whenever there is involvement of the cavernous sinus, involvement of the orbital apex, both orbital exentration is required. Whenever the both orbital exentration is required, it is not advisable to do a surgery, but we can do for some systemic therapy or a CTRT. And the ICA encasement, whenever there is encasement of internal carotid artery in the malignant tumor, it is considered to be inoperable. So there are the few cases where we see how when it is unresectable cases. So this is a case where there is encasement of the both internal carotid artery. In this case, this malignant tumor, so it is an unresectable case. And the second one on the right side, there is a massive brain involvement with the brain edema. So it is also the one of the contraindication, because we won't be able to achieve the good margins, and there will be R plus in this case. So what will be a complications, whether it is open or endoscopic surgery? As a number of the cases overall of skull base are very less, we are not able to pool the data from a single study. So this Ian Ganley and Jatin Shah et al. In 2004, they did an international collaborative study, and they collected the data from the 17 institutions worldwide. And they found that there was a mortality rate of 4.7% in the skull base cases, open as well as endoscopic both combined, and the morbidity rate was around 37%. That is, complication rate was around 37%. And most common complication, if you see, there is a wound complication that could be infection or dehiscence or flap necrosis that comprise of 20% of the entire gamut. Then there is a CNS related complication like the CSF leak, meningitis, pneumoencephalus, CV stroke that comprise 16% of entire population, that entire study. Then the orbital complications. Orbital complications could be a nasolacrimal duct obstruction, tract obstruction, diplopia. Diplopia could be because of that extraocular muscle damage, or it could be because of abducens nerve palsy. Blindness because of optic nerve injury or the optic chiasma injury may lead to the blindness. And systemic complications like renal, cardiac, pulmonary, metabolic, urinary tract that comprise of the 5% of entire population study. So what are the factors that determine the morbidity as well as the mortality in this cranial based surgery or skull based surgery? That are the major, if patient is having a major medical comorbidity, the chance of the complication are twice or thrice compared to a normal individual. If the patient has previous radiation, the chance of complication definitely increases. And the patient has a dural or the brain invasion where we need to resect the dura or the brain, the chance of neurological complication definitely increases. The CSF leak rate initially was 25%, but with the use of this Galeal pericranial vascular flap, there is a reduction of the CSF leak from 25 to 6% overall. And this 6 to 7% is standard till now. After this complication, we'll go for a survival. This chart is taken from the MUSES study, that is a multi-institutional study for the sinonasal carcinoma, which has been treated by endoscopically. And if you found that there's an Italian paper from Marco Ferrari, but they have collected the data from the 5 institutions of the worldwide, 3 from Italy, 1 from Canada, and 1 from the India, that is TMH. And they found that the survival is different in different histologies. In this left side chart, if you see the Kaplan-Meier chart on the left side, the survival is worst among the neuroendocrine tumor, that is gray one, and the blue one, malignant melanoma. The survival is the worst. The good survival tumors are the estrogen neuroblastomas, and the non-adenosystic minor salivary gland tumors are the good survival rate. And if you see on the right side, obviously as the stage of the tumor increases, the survival decreases. This purple one is a stage 4B, obviously the survival reduces. And this is also another one, Kaplan-Meier chart on the left side. It shows the survival according to the age. If they have taken a cutoff age as 54 year. If the patient is more than 54 years, the survival is poor. If the patient is 54 or less, the survival is better in all the histologies. And then the most important thing there to be considered in the sinonasal pathology is the grade of the tumor. If you see the high grade or low grade, they have the different survival. And this green color, if you see, there is a low grade tumor has a good survival. But if the blue color, that is a high grade tumor, that is a poor survival. In all the state, that is whether it is SCC or a mesenchymal tumor or whether it is ITEC, low grade tumor will have the poor survival, while the high grade tumor have the low grade tumor has a good survival, while the high grade tumor has a very poor survival. So grade of the tumor and the stage of the tumor are the two important criteria in sinonasal malignancy that will determine the survival of the patient. So margin status, definitely, as we are already discussing, the margin status, if it is a R0, that is blue line, it is a good survival. If it is a R1, that is red line, it is a very poor survival. So whether it is endoscopic or whether it is open, margin is a key factor for the survival. For adjuvant treatment, when we compare with the adjuvant treatment, and what we found is that whether we go to the adjuvant CTRT or adjuvant RT or no adjuvant treatment, survival remains the same. But the thing that changes is the locoregional control. After the adjuvant RT, the locoregional control is much better compared to a no adjuvant RT. So survival remains statistically there is no difference in survival, but the locoregional control is much better when we give adjuvant treatment. So this is also one of the important factor nowadays coming up. Quality of life. What will be my quality of life after this anterior skull base surgery? So skull base tumor, as you know, is heterogeneous group of tumor with a variable anatomical extension, different origin of histopathology, proximity to the critical neurovascular structures. So disease itself as well as treatment both affect the quality of life of patients suffering from a skull base tumor. So when we did a cross-sectional studies of quality of life after skull base surgery, we have found that 26 to 63% of patient as a quality of life is worsened in that case. And endoscopic group definitely does much better in the quality of life in all the domains compared to open group. And we measure this quality of life with the help of this skull base inventory. There are the different 20 to 50 questionnaires are there, which will be filled by a patient, and we measure how they are doing after the skull base surgery. And mostly we see the quality of life or symptoms related to the nasal related problem, whether there is any nasal synechia or the crusting is there or this. So most of the time after 1 year this nasal related problem generally reduces markedly. Vision related problem is commonly seen. It is if there is a blindness because of optic nerve injury or diplopia because of the muscle injury or the abducens nerve palsy. This vision related problem is very annoying to the this patient, and definitely when patient having a diplopia, it greatly reduces their quality of life. Neurological and cognitive problems are common after that dural resection or the brain resection, and the open surgeries where we need to retract the brain. So it may lead to the brain edema post-operatively, so that the cognitive they have the reduction in the cognitive impairment. So they have the cognitive impairment as well as the neurological problems are common after the open surgical procedure where we need to retract the brain or resect the brain. Endocrine related problems are mostly seen when we go to a transcellular approach or after the radiation of that skull base that is affecting the pituitary gland. So endocrine related problems are also common in that post surgery group. And the other most important is the cosmetic, which is most common in that open approaches. Obviously this emotional, financial and social family issues always remain with the skull base surgery, which we actually neglected aspect of the skull base surgery. So overall, if you see, thank you so much. This is our team of head and neck surgery at SCG Asta. Overall, if you see, this skull base surgery requires a lot of planning, lot of the expertise and the multidisciplinary management of each and every histologies. Thank you so much, and I would like to answer your questions.
Thank you so much, Parin, for an excellent overview of skull base tumors and its management. There are few questions from the trainees. Nikhil has asked, which powered instrument is used for debulking or resection in endoscopic approach?
So we use the micro debrider, but if possible, the micro debrider, the bleeding is very more in that micro debrider group. So what we do is first bipolarize that tissue, and then we do a micro debriding. So this is how we can reduce the blood loss.
What is the usual post-op order for patient, and you describe the post-op management?
Post-op management is different from different individuals. Suppose if you have not breached the cribriform plate or dura, then there is nothing specific management for that. It is a routine head and neck management. But suppose if you have breached the dura or we have resect the dura, then we ask for a 72-hour complete bed rest. Air bed has been provided. We start the patient on that anticoagulant like Lexin, as well as we have to avoid the straining. We start antitussives, and we normally start with the injection ceftriaxone. That is that to cover the spectrum of that which can penetrate the CSF and the spectrum of the microbes. So we always start with the ceftriaxone 2 gram BD, and the routine the antiemetics this. So normally after 72 hours we ask the patient to mobilize. Suppose there is a CSF leak in our patient, we will confirm it with the beta-2 transferring, and our protocol at our institution is to take the patient as early as possible on the same day or the next day for the repair of the CSF leak. There is a dilemma whether to wait for that patient, whether to do a lumbar drain or no. But what we follow is to take the patient immediately or the next day for that CSF leak repair, so that the contamination of nasal cavity and that is contamination of the brain or meninges from the nasal cavity does not take place, and the chances of infection or meningitis greatly reduces, and we don't have to keep them on the long-term meropenem or vancomycin. So whenever there is a CSF leak, please take the patient immediately or the next day for the repair.
Is there a compartmental resection concept for skull base and PNS tumors?
Sir, it was in previously, but it was associated with a lot of morbidity and the mortality, and also the cosmetic disfigurement. So in order to reduce that, what we have discussed, in order to reduce that, we are using that sequential resection and taking the margins from all the sides, so that not only reduce the our complication rate, but we are able to achieve the same survival as well as the local regional free disease free control.
Yes, so this is in a way, like what Dr. Steiner told us about the endoscopic laser. So this is a conceptual difference, and then it has resulted into an equivocal survival and outcome. So that's why compartmental dissection is now out with a combined approach or endoscopic approach. Biplab has asked indication of NSCT in paranasal sinus. Are they same as oral squamous cell carcinoma?
No, Biplab. It all depends on the histology of the tumor. As already I will discuss, so various histologies are so chemosensitive, like SNRC, then the esthesioneuroblastoma, Himes grade 3 and 4. So we'll always like to give that NSCT in that case. And sometimes if there is a good response, that is a CR, complete response, so we can consolidate with that with the definitive CTRT instead of going for a surgery also. So there are the means, it depends on the histology of the tumor, whether this histology is chemosensitive or not. We always consider the histology is a king, which will determine our NSCT guidelines.
Another two question, one from Nikhil and one from Rakesh, is the indication for neck node dissection. How you manage lymph node dissection?
So I already mentioned two histologies like SCC and the ENB are the two histologies that have more than 20% of neck node metastasis. So when we do a PET scan, if there is a clinical or radiologically evident node in the neck, then only we do the neck node dissection at the time of surgery. If there is no clinical or radiological evidence of neck nodes, then we will we won't do a neck node dissection. We will like to cover that neck into field of radiation.
Another question by Farhana is that whether red plate technique is attempted, is it used in clinical practice?
Sorry, sir. Pardon, which technique?
The red plate, radiation plus platinum. The Japanese technique of radiation and platinum, which was once upon a time was researched, but Farhana, it is not a standard of care today.
Yeah. So it is not a standard of care. It is means even in the higher institutions and the Pittsburgh and the MD Anderson, they are not following this technique.
Can we use NSCT for orbital preservation is another question for Farhana.
Yeah, so we already discussed Farhana. Depend on the INAT classification, we can preserve the orbit or we have to remove the orbit. So it all depends on two things: how what is the depth of infiltration of the orbit. If it is limited to the periorbita or the extracornal fat, we can definitely preserve the orbit with the help of NSCT. Depend on the histology of the tumor. But if it infiltrating the orbital contents, frank infiltration of orbital contents, optic nerve, then we can't preserve the orbit even with the NSCT.
Another question is from Rakesh. What margin is considered as R0 for PNS tumors?
So that is a good question, because in PNS the cavity is very small and we won't be able to get a good margin as like 1 centimeter or more than 1 centimeter for PNS. So what we do is we map the tumor. We first take the normal mucosal margin surrounding the tumor, that is around 5 mm, and send it for a frozen examination. So I think this 3 to 5 mm margin surrounding the tumor is considered to be an adequate for the paranasal sinus tumor because of the location of tumor and the space constraint. Even in the dural margin, 2 mm is an ideal dural margin. If it is free of tumor, we consider to be an adequate.
Rakesh has also asked whether early stage rhabdomyosarcoma or osteosarcoma, what should be the plan? NSCT followed by surgery or upfront surgery? This is early stage he is asking.
Yeah, always rhabdomyosarcoma should be given chemotherapy. It is a highly chemosensitive tumor. If it is responding well to the chemotherapy, then if there is a complete response, as I was told, then we can consolidate with the CTRT. So in rhabdomyosarcoma, NSCT is the treatment of a choice. For osteosarcoma, if it is an early stage like T1 or T2, we can resect it and followed by a adjuvant RT and followed by a maintenance chemotherapy.
I think the questions are finished because the last question Nikhil has asked is how lucrative is head and neck with skull-based oncology as a career option for ENT, MCH, head and neck, HNO and SB. So Nikhil, I think you should not ask as lucrative. You go to these subspecialties for passion. The skull, as he rightly said, it is 3% of the entire head and neck incidence. So if you have a passion, you go for it. It is all into your inner self feeling that you want to do it. As you know, cancer is also you took as an NB as a career, this DRNB as a, or surgical oncology as a career, if you have a passion for that. So during your training, if you feel that this is an area which interests you so much, then you can subspecialize into it. I don't think there is anything which is lucrative or non-lucrative. That will come at a later date.
Yeah, exactly, sir. You have given a perfect answer. Passion is what you should go for it. Otherwise, everything is a myth. And the last question that Nikhil has asked you, what are the books you suggest for that skull base? So there are plenty of books. One is a comprehensive management of the skull base pathology by Iya Bhanna. The other is a Paul Donald, which is a pioneer of that Paul Donald book on that skull base pathology. Ivo Janica, the master from Pittsburgh, has he has written a book in 1980s around the skull base. So that is one of the best book. There are various other books are available, but these three are the basics which you should read it completely.
Thank you so much. I think that finishes off our question and answers. And Parin, thanks once again for giving an exhaustive overview and also answering our trainees' questions very adequately. Thank you so much.
Thank you, sir. Thank you, sir. Definitely, I would like to come again and again to spread my knowledge of skull base. Thank you so much.
This will be archived on the NB site as a lecture so that the trainees can go back again and listen to it and understand again if they have any queries. Thank you. Arif, over to you.
Thank you, faculty members and trainees for joining in this webinar session.